And pharmacology rolls on. We're moving into the last part of chapter 6, where the steroid anti-inflammatory drugs. You can pause this if you want to check out these comics. I like them, but I want to keep going. So let's click it. There we go. So I want to start by just referencing where our endogenous steroids come from. Basically, we have our adrenal glands, and you can see you don't need to know these specific areas on what comes from what. The book mentions the mineral corticoids. We're talking about this group of glucocorticoids. That's our corticosteroids coming from this adrenal cortex right here, not the adrenal medulla, but the cortex itself. Cortisol is our classic endogenous steroid, or basically our drug that is produced within the body. And most people think of cortisol as a stress type hormone that gets released when we have these situations where fight or flight kind of situations, or in extreme, I guess, not trauma, but stress to the body, whether it's from a disease or from some other kind of outside source. Cortisol in itself has a number of effects, right? And so buried in there, so you got this bullet. There's a whole bunch of stuff in here that it does, and buried in there is, hey, there's some anti-inflammatory stuff. That's awesome. But then we also have all this stuff. So when we talk about cortisol, or when you hear things about cortisol, a lot of times it's to the effect of, right, in periods of stress, we like it because it helps our body overcome and adapt to certain situations. But those who remain stressed and have high anxiety for long periods of time, high levels of cortisol can have some pretty significant negative effects over time. So we try to limit the amount of cortisol that's in there. We're going to focus on the corticosteroid part. And your book, if you read the first part of your text, this is your text on this is pretty good because it doesn't go super in depth. But your text is talking about the balance of trying to get all the anti-inflammatory stuff out of these drugs, but not, create drugs that do all the anti-inflammatory stuff, but not all these other things. So this is what we want from our anti-inflammatory steroid corticosteroids. And they do a lot. They are the steroid anti-inflammatory drugs are the most powerful anti-inflammatory agents that we have access to. Just look at stabilizing cell membranes. We have all that permeability and the changes that go on there. So we're going to stabilize those. We're going to limit the amount of inflammatory mediators that are out there. The actual cells and the enzymatic part that's going on, we can limit that. And then, oh yeah, there's this whole pathway that we've been talking about that has prostaglandins, leukotrienes. And so you see this and you're like, what? We didn't have that. Let me give you something that you do recognize, right? It's this one. It's that eicosanoid cascade. We come up here, and here's the corticosteroid right at the top to stabilize this cell membrane and go, look, we don't need all this arachidonic acid be coming out here. And, we don't even let the COX-2 and 1 do their thing because we don't even have the arachidonic acid released from the cell membrane. So yay for steroids and that's basically the main driver of the anti-inflammatory process. Now, I referred to it on the previous slides, but box 6-1 has some nice bullets on the overall effects of the glucocorticoids or corticosteroids. I'm going to use those back. I'm going to mainly use corticosteroids because we're focusing on the anti-inflammatory part, but they're all glucocorticoids made in the same area. But anyway, look at box 6-1 that has that kind of that rundown of all the effects that you'll need to have an idea of. As far as administration of these things, this is a good one. This is our classic methyl prednisone. This is a Medrol dose pack. Sometimes you'll hear that you might have taken this. This is a common prescription for just your classic anti-inflammatory medicines. This is a 5-day deal. 1, 2, 3, 4. Actually, there's 6 days. 1, 2, 3, 4, 5. Yeah. So you take a whole bunch. This is the first day. You take the 6 the first day, and then you start tapering down. That's kind of the way that goes. There's a number of asthma drugs that are in here. This drug itself actually has a bronchodilator, as well as that kind of an extended release steroid anti-inflammatory to manage as a kind of preventative step. And then we go into the topical side. Hydrocortisone, you've probably seen and used hydrocortisone for some just skin type inflammatory allergy inflammation kind of things. And then now there's also beyond just the dermatologic interventions, there's other topical creams and anti-inflammatory, steroid anti-inflammatory medicines for actual anti-inflammatory conditions. So from a, indications, what do we use corticosteroids? When do we use corticosteroids? This is an easy one, right? Because we're already talking about the inflammation and injury stuff. So definitely in this acute inflammation, right, we have the tissue mediator. Here's our eicosanoid cascade all in one neat little box. But all this stuff, right? So all this stuff, that is where the steroid anti-inflammatory medicines can come in and kind of stabilize and prevent some of these inflammatory processes from getting out of control. Then we talk about the chronic ones, right? Where I have tendonitis, I have tendinopathies, I have all this kind of stuff. And so that's another, long-term musculoskeletal inflammations. Man, that's kind of an interesting topic, especially when you get into the longer-term tendinopathies. When you look at the pathology that, that tendinopathy brings with it, a lot of times, there's some degeneration. The soreness and pain comes from these areas that haven't healed. So that inflammation process started, got stalled out sometime. You have this excess granulation tissue that just gets stagnant and stays there, starts to degenerate, and you get fibrotic tissue, and then you keep working on it. None of there, I have said nothing about ongoing inflammation. So there is some kind of does the anti-inflammatory medicine actually works for these long-term, because the pathology is not there. There's not active prostaglandin synthesis. There's not active vasodilation and permeability and all these cytokines and chemotaxis. That's not happening right here. So it's interesting, and some of the literature that you guys read this week will address at least one area of that. But then beyond the musculoskeletal realm, what other indications? It's basically anything that has this ongoing inflammation, right? Any conditions that have a long administration or this long state of inflammatory, inflammation, basically. And so when you look at things like arthritis, even osteoarthritis, things that have this pretty significant inflammation where steroid anti-inflammatories can be helpful. I told you, or I put some pictures in of not only rheumatoid arthritis, but gout, mainly because those two conditions are common long-term inflammatory conditions, and they are discussed within your text. As far as what you have to know about gout and rheumatoid arthritis, ultimately all I want you to know is just the presence or that they're a common indication for using steroid anti-inflammatories. You should know the basic pathology behind this, behind rheumatoid arthritis, and how certain antibodies can start to attack the cartilage and start to break down that cartilage there. Same thing with gout. You should know that it's a uric acid issue, and these crystals start to develop. That's where the inflammation comes from in these joints. Multiple sclerosis, it's not in the book, but again, you should have an idea what that pathology is and how that leads to this chronic inflammatory issue. Respiratory conditions, especially people that struggle with asthma and reacting to certain things, and the inflammation that comes along with that, is another common indication for having to use corticosteroids. Box 6-2 has a number of adverse effects. And if you look at it, I'm on page 131 here. When you look at it, you're like, dude, that's a full page of just words. It's all reading. Where's my bullet points of just a couple things? This is not a Coulomb-produced box, by the way. So ultimately, what I want you to have, when you look at each one of these, just look at the basic. All right, osteoporosis as a long-term. Okay, and you can read why. Hypertension. Okay, there it is. And so instead of reading this whole thing, just kind of get the main, bullet point from the bullet point. Maybe that's a better way to say it. I've put some stuff in here as some common ones. I think the obvious one, people who are on corticosteroids, especially for long periods of time, because of the the effects on protein synthesis and breakdown and gluconeogenesis. There's a concern about those with diabetes, with obesity, or it could start to cause kind of an obese situation. So that's a big one for me. And then again, like I said, I listed a number of them down there as well, and you can definitely look at those when you can. All right, so here are the drugs that we have for your common medicine notebooks. Again, like the non-steroidal anti-inflammatory drugs, there's a whole bunch more that you'll come in contact with. I don't want to give you 20 drugs here, so I limited it to 4 common ones. Definitely hydrocortisone. That's it's prescription and non-prescription strength. But then there's also, this is our Medrol, one for musculoskeletal stuff. Dexamethasone and diclofenac are also common ones. So you can look at that. I think that's a cute sign. And other than that, I think I will end it there.